Hello, everyone. I'm Colleen Becker, a policy specialist with the NCSL Health Program, and on behalf of the National Conference of State Legislatures, I'd like to welcome all of you to today's webinar, Surprise Billing and Pharmaceuticals, Two Healthcare Cost Factors, Part 1 of a three-part series. I'd like to remind participants that NCSL is a bipartisan membership organization of all 50 state legislatures and the territories. Our members include the 7,353 legislators and thousands more legislative staff. NCSL advocates for the interest of states and provides policymakers the opportunity to exchange ideas. Today's webinar is a platform for information exchange and engagement. Over the next 60 minutes, we encourage participation through our chat box, so feel free at any time to type your questions or respond to any questions in the chat box, which is in the lower left hand of your screen. So to begin building some comfortability with the chat function and to also learn who is on the line today, I invite you to type in the state from which you are calling now. And I want to briefly mention how to access the slide decks. Above the presentation, you will see a couple of tabs with one of them labeled Resources. Here you can find and download a PDF version of the PowerPoints used today. Another tab is labeled Speaker, and that's where you can read the bios of today's esteemed speakers. You can access these tabs at any time during the presentation. Also, today's webinar is being recorded and will be available on NCSL's website within the week. And before I introduce today's fantastic panel of speakers, I want to thank Arnold Ventures for their support of today's webinar. So our first presenter today is Ms. Chiquita Brooks-LaSure, Managing Director at Manat Health. Ms. LaSure has more than 15 years of experience in health policy. As Deputy Director for Policy at the Center for Consumer Information and Insurance Oversight within the Centers for Medicare and Medicaid Services, and earlier at the Department of Health and Human Services as Director of Coverage Policy, she led the agency's implementation of ACA coverage and insurance reform policy provisions. Her current work focuses on helping clients understand the implications of regulatory and legislative policies across private insurance, Medicaid, and Medicare. Our next presenter will be Assemblyman Jim Wood from California. Assemblyman Wood, a forensic dentistry expert, was elected in 2014 to serve the people in California's 2nd Assembly District, and he has been the chair of the Assembly Health Committee since early 2016. Assemblyman Wood's priorities include healthcare, environmental protection, and economic development, especially in rural areas. Wood has been involved in numerous consumer-related healthcare laws, including expanding access to medical, dental, and mental health care in rural areas, protecting consumers from surprise billing, and lowering the cost of prescription drugs. And finally, we will hear from Representative David Knight from Georgia. Representative Knight was elected to the Georgia House of Representatives in 2004 and sworn into office in 2005. Knight proudly serves House District 130 and currently serves as chairman of the Appropriations Subcommittee on Higher Education and the House Sportsmen's Caucus. Representative Knight has been a practicing certified public accountant for over 20 years and holds memberships in the Institute of Certified Public Accountants and the Georgia Society of Certified Public Accounts. And with that, Ms. LaSure, I'll now turn it over to you.
Thank you so much, Colleen, and thank all of you for having me here today. It's such a pleasure to speak with you. I'm going to spend a few minutes just talking about some of the factors that are leading states to consider how they might control healthcare costs in their states, and then give a brief overview of some of the strategies that states are employing before turning it on to our next speakers. First, to start with, as you all know, states are covering a significant portion of healthcare costs in this country, primarily through their Medicaid programs, but also through state employee health programs and other types of programs. Further, consumers are thinking and concerned about healthcare costs, their affordability of coverage, both premiums and cost sharing like deductibles, are a growing issue across many forms of healthcare coverage, including employer-sponsored insurance. And at the same time that health care costs are a significant portion, they continue to grow. Hospital and physician services are the largest drivers of healthcare costs today, as you can see from the chart that I have on the slide. And hospital consolidation and other forms of consolidation have contributed to these costs. And at the same time, some of these areas are growing. Prescription drug costs are a relatively small percentage, 10%, but the growth trend is growing, and they're growing as a share of healthcare costs. So those are a little of the overall big picture dynamics that we see. And of course, every state has its own specific dynamics and market forces at work. And different states will have different health policy goals. But there are some trends that we're seeing across the states. First, addressing prescription drug pricing. And as I mentioned, prescription drugs are about 10% of healthcare costs. But there is concern about the growth of prescription drugs costs both on consumers and on various payers now and in the future, as we see potentially life-saving but expensive therapies coming to market. There's a desire to make sure that patients have access to the care that they need, but also in a way that's affordable to those who are paying. Provider reimbursement, and we're seeing states look at the rates that providers are getting and thinking about whether they should have some type of rate setting, whether in the state employee plan, parts of the individual marketplace, or in Medicaid. And evaluating provider consolidation. So over the last couple of years, we've seen increasing consolidation of different systems, and state attorneys general in most states have authority to review those types of arrangements. What we tend to see is that in areas where there is more consolidation, the average cost of a hospital stay go up. And so in looking at the trends in healthcare costs, consolidation on the provider side is one that policymakers are focused on. Plan consolidation or lack of competition is also of concern for some policymakers. In the individual market, when adding one insurer in a county when there's only one insurer tends to lower the premium on average 1 to 4%, depending on the market. And we'll also spend some time both in this webinar and I think future ones talking about protecting consumers from surprise billing and concerns that people have when they expect to pay a certain amount for a service and then are surprised to find that the service was actually out of network. So first, we're going to take a closer look at some of the prescription drug policies that states are considering. There really are a range of ways that states and the federal government are looking at drug pricing. There's been increased interest in looking at the role of pharmacy benefit managers, increased interest in understanding their role in drug pricing, how they serve, and what part they have in what the cost that people pay when they see the pharmacist. And we'll hear more about one state strategy in just a few minutes to address the role of the PBMs. Instituting affordability review. So these boards or commission may look at prescription drug costs across the system and make policy or spending recommendations. So for example, Massachusetts has been a state with a cost containment commission for the last couple of years, looking at healthcare costs across multiple payers in the state of Massachusetts, and they're increasingly focused on different parts of the healthcare system and are now taking a closer look at prescription drug pricing and will be doing so moving forward. promoting price transparency, so requiring drug manufacturers to provide additional cost and pricing information has been something that we're seeing across the states. And that could look different in different states. So in some states, we're seeing more requirements where there are specific requirements that all manufacturers must adhere to. And then some states are using it more as a stick. So for example, New York passed legislation requiring states that didn't enter into a supplemental agreement with the Medicaid program to provide additional information about the pricing of their products. So we're seeing different types of policies across the nation. Increasing state purchasing power. So as I just mentioned, states are, through their various programs, providing health care in many programs. And so some states are looking at ways that they might pool their various places where they buy prescription drugs to try to negotiate better prices for those covered lives. And there are and is continued interest in even working across states, so states doing multi-purchasing payment pools for their prescription drug costs. And finally, some states are trying to determine whether allowing drug importation, so getting drugs, usually thinking about Canada, getting drugs from other countries that get better discounts from drug manufacturers, and as a way and a strategy to try to bring lower prescription drug costs to their states. So again, we'll talk in just a few minutes more about strategies around prescription drug spending. I'm going to turn now to give a brief overview of some of the strategies that we're seeing on surprise billing. And surprise billing occurs when someone who has coverage, so an insured individual, inadvertently receives care from an out-of-network provider and is charged more than they expect to pay. One of the, I think, easiest examples to think about is a patient schedules surgery. Their surgeon, their doctor, they know is in their network. Their hospital where they're going to get their care, they know is in their network. But one of the services that they receive during the course of their care is out of network. So for example, the anesthesiologist is in a part of the network. And as a result, when the patient gets the bill for the coverage, they end up owing more than what they expected because the price that they're seeing is an out-of-network cost. And there are many examples across the nation, and many states are trying to think about strategies to address these. There are generally two mechanisms that states are using. One, arbitration, where the state establishes a process where, in order for there to be an agreement between the insurance companies and the providers, and that's a strategy that we see in the state of New York. And we'll see hear more in just a moment on a second strategy, which is rate setting, which we see in the state of California. So as you're probably aware, there is a lot of activity at the federal level here in Washington with Congress very much focused on surprise billing as well as prescription drugs, but really focused on surprise billing. Recently, the Senate Health Committee, the key committee in the Senate, passed legislation out of their committee to address surprise billing. And the House has a few committees to act, but the Energy and Commerce Committee has also passed surprise billing legislation. And so there's a lot of focus on whether or not Congress will be able to pass legislation by the end of this year or perhaps early next. And whether or not that legislation does pass, there will still be a very critical role for states in trying to address surprise billing if they choose to. Both of the key committee bills that have passed out of Congress defer to state regulation. So in the current forms, which of course could change during the legislative process, any state that already has surprise billing processes in place would keep them, and states would still have the ability to establish new processes rather than follow the federal standard. So there is likely, if Congress passes legislation, still to be this deference to state legislation if states choose to act. Another key area where states will still have important authority in surprise billing, even if we see action at the congressional level, is that the federal legislation may not be comprehensive. And for example, one area that a lot of states have focused on are focusing on ambulances. And in the current bills out of E&C and HELP, those ambulances are not addressed. And so states will continue to have opportunity to fill in the gaps that may be left by whatever federal legislation does pass. So there will certainly be a robust, as always, role for the states, regardless of what we see happen at the federal level. Last, I'll just leave you with a map of a number of the states that have passed legislation, whether just partial protections or more comprehensive protections, and many more states continue to think about advancing legislation during their sessions. So with that, I will turn it back over to Colleen, and I'll be happy to answer any questions at the end.
Thank you, Ms. LaSure. And as a reminder, please enter your questions in the box on the bottom left-hand side of the screen, and we'll address it during the Q&A portion towards the end of the webinar. And next, we will hear from Assemblyman Jim Wood. And Assemblyman, please tell us a little bit about what's going on in California related to surprise billing.
Well, first of all, thank you very much for the opportunity to participate today. I think you need to back up a few years to really, as we understood it in California, when we were working on this particular piece of legislation, it's something that had plagued us in California for 39 years. And as you heard earlier from Brooks LaSure, it basically comes down to this: patients thought they were doing the right thing. They thought they were going to an in-network facility, which they were, only to find out that somebody provided a service that was not in the network. So it could have been an anesthesiologist, a radiologist, pathologist, whoever, that the patient never met, they didn't choose, and had no control over choosing them. What's interesting as well, as we looked at this more, you might just say, well, that's just, we can blame the doctors, you can blame whatever, but in a lot of cases, doctors don't always know all of the networks that they are a part of. It's complicated. Things change, and people merge in and out of networks, sometimes not knowing that. I know that because I was a practicing dentist, general practice, for over almost 30 years now. And I found myself a part of networks that I really didn't recall or had any idea that I was a part of. And then, but I certainly did know the ones I wasn't a part of. Basically, the scope of the bill affected non-emergency services. So these are people that went to in-network facilities for surgery, and then found that they were being later balance billed by an out-of-network doctor. California protects, in many ways, emergency services, and we really did want to have consistency there. But at the end of the day, after a year's worth of work on this, we really didn't actually come up to a way to have it incorporated so there was absolute consistency between the two. That has led to a bill that was introduced in 2019 to actually address the emergency services that we found, and that bill is still going through the process. You heard a little bit about ambulance services not being a part of the federal legislation. Air ambulances were not in California. They are now. That bill was, I believe, was signed in October. We have heard cases where sometimes the air ambulance bill was actually more expensive than the treatment the patient received in the hospital. And people thought that they have no control. If you're in an automobile accident or some other medical emergency, you don't have control over which air ambulance might swoop in and take you off to the hospital. Now that's significant in the area I represent. I represent a very large rural district, and there are a couple of providers, but I would venture to guess nobody knows who is part of which network as far as air ambulances. So the goals were to make sure the patients only got billed for the in-network cost sharing, especially when they went to all the effort to go to an in-network facility. The goal also was to help control healthcare costs and therefore helping with premium costs as well. The payment that we came up with was the payment methodology was based on rates paid by public and private payers, and not just the billed charges, what we call the sticker prices. I'm sure everybody has seen an explanation of benefits from their insurance company and looked at that and go, wow, that bill doesn't look anything like what the insurance company paid and what my actual cost is going to be. And that is indeed the reality, because most physicians have contracts with multiple providers, and it's only if you are completely uninsured that you might be subjected to what we call the sticker prices. The other goal was to make sure that, just basically you were only responsible for what the in-network costs were going to be. Of interesting part of this was that, and this was pushed back from the insurance industry, we wanted to be sure that if you did see an out-of-network doctor and you ended up paying the in-network price, that would actually apply towards your deductible, even though that doctor or that facility, or actually just the doctor, was not a part of that part of the network. Why should you, as the consumer, have to pay additional towards your deductible, especially in a situation where it was an out-of-network provider? So there was a lot of discussion around that, but at the end of the day, that was included in the bill. And as you see on the slide, the facilities included hospitals, ambulatory surgery centers, and other settings as well. We wanted to stop the out-of-network providers from billing or collecting more than what they should be. So now the way it works is that the out-of-network provider isn't supposed to bill until after they know what the in-network cost is going to be. And if they did do that and billed anyway, they're supposed to refund the patient. And if more than 30 days has happened, they actually are going to be charged interest for that. Not aware of how that part of it is going, quite frankly, but I can see that that is certainly a disincentive for an out-of-network provider to sort of go around the system to an unsuspecting consumer. The results, we've we believe they've actually been pretty good, based on the actual rates paid by public and private payers instead of the billed charges, is what I mentioned. So the way it works in California is that it's they're reimbursed at either 125% of the Medicare rate or the average contracted rate, and that's basically how similar services are in the similar geographic area are reimbursed. Now, the state is the one who actually went and created the methodology for this, because this information is proprietary. And when I was practicing dentistry, I didn't know what my fellow colleagues' contracted rates were. with certain plans, and that is protected and confidential. So there was significant discussion about how we protect that information, and so we have allowed the state regulators to have oversight on this and actually come up with the methodology to do that. It's also created called an independent resolution process, basically a way to protest. It's an appeals process that gives doctors a way to appeal for a higher payment. They have to make their case, and it goes through the Department of Managed Healthcare and the Department of Insurance, and that depends on who oversees that particular entity. And in California, it's a little more complicated, I think, than it might be in other states. But basically, that process, which is binding, it still permits the either party to litigate if they choose to. So you'll see literally in 2 years, there have only been 68 applications, 45 withdrawn or ineligible for one reason or another, 20 are still pending, and 3 were decided, and they were all decided in favor of the insurance plan. We're monitoring this closely. We have pretty strong network adequacy protections in California through our insurance code and our Knox-Keene Act. And the protections are there basically to make sure the consumer receives the care that they need when they need it. This reiterates the insurer's obligation to comply with existing network adequacy requirements. The concern was that insurance companies would simply stop contracting with doctors. We haven't seen that. We have seen that, and I'll get to that in the next slide, but we have seen some things that do cause us some concern. And ultimately, we really do want insurance companies and doctors to contract with one another, which is to the benefit of consumers. Maybe there are some unintended consequences. Anything we do at a legislative level is a potential for that. We have seen that health plans have not just said we're not going to contract with doctors. There may be some anecdotal cases there, anecdotal evidence of that, but the reality is that is not an en masse issue. And we're still working with our Department of Managed Healthcare to see if that does become the case, that we need to have either a response by the regulator or a legislative response, because that's certainly not the intent. We do know that there may be an issue with anesthesiologists. We know that at least one plan decided to use this as a way to really hammer down the fees, and significant in some areas, but it's not been widespread. It actually was a geographical issue where one group of anesthesiologists had a significant component of the market, and I think you all know when you got control of the market, you can pretty much set the prices you want. But we are looking at that. We don't want this to be an issue, and we will be pursuing cleanup legislation, and we are working with anesthesiologists. But also, it's interesting that Ms. Brooks-LeSueur talked about New York and the other style. Ours is basically setting a rate, and the New York style being a baseball style arbitration, which means that if anybody's a baseball fan out there, you're the player and you say this is what I want to be paid, and the owner says this is what I'm willing to pay you, and if you guys don't agree, then you end up at arbitration. With the New York style, basically the rates have been the doctors have been asking for 80% of the at the 80% rate. I lost my phrase for that. My apologies. The 80th percentile. So that's a pretty high reimbursement rate. And at the end of the day, while there is some evidence that New York citizens have seen some relief from this, there's also been associated with a significant increase in the cost of care to people of New York, and that is an unintended consequence. So I know that that baseball-style arbitration was something we debated in California, and we pushed back and did not get into our report. but like I said, overall patients have been helped, but overall costs were not controlled, and that's a significant concern to us. So that concludes my remarks on this. It is a complicated issue. I know that Congress is working on this. I know other states are working on this. And as anything we do in the legislature, should there be an unintended consequence or ways to improve something, we do have the opportunity to go back and look at that again. And in this case, we certainly will. And so that concludes my remarks.
Thank you, Assemblyman. And now we're going to turn our attention to Representative Knight, who is going to talk about experiences in Georgia related to prescription drugs and pharmacy benefit managers.
Thank you, and again, I appreciate the opportunity to participate. I apologize for the lack of slides, but before we do get to the 2 slides, I think it would be wise to go back and look again, the pre-19 landscape, not only in Georgia, but perhaps relatively across the states. Obviously there's a focus on the ever-increasing cost of prescription drugs, and it's playing out with problems of access, quality of care, and then certainly a never-ending cost to the state for its managed care or its state health plans, or even commercially. We're seeing this all over the board. But prior to this, if you look at the landscape, a lot of the states have come in and we're dealing with issues such as fiduciary duty, audits, MAC pricing, some bit of the oversight. In Georgia, in 2017, along with my bill, passed protections against copay clawbacks, gag clauses, retaliation, transaction fees. Specifically in 16, it was the Pharmacy Audit Bill of Rights, where we saw that the PBMs were recouping for clerical errors and basically taking advantage of these types of errors, going back in hindsight and collecting from the pharmacists. We also in that bill started to give the Commissioner of Insurance enforcement authority over the Pharmacy Audit Bill of Rights. The same year, we also addressed the MAC pricing, which provided the sources that were to be used in determining the multi-source genetic drug pricing, making sure that those pricings, the pricing was updated every 5 days. And we started going in again to the appeals process with commissioner oversight. And, we look back, and as of, like today, while the Audit Bill of Rights, remains effective, we look back that we've got to go back in and strengthen and close loopholes. There's still volumes of audits that remain a problem. And basically what we're seeing is that no matter what the state has done, and I'm sure this is the case in most states, the PBMs will come in and change definitions, change processes, and we're seeing, I guess, like most of the other states, there's a complete lack of transparency, and basically the PBMs are adopting new methodologies that they argue are not MAC pricing, and basically ignoring the law. Now in 17, we came in and did the Pharmacy Patient Protection Act. That was prohibiting mandatory mail order, again, the gag clauses, clawbacks, and such that we just spoke of. But 19, here's where we did some things that were different. We wanted to go in and look at steering. And I would tell those listening that there's two sides that the states, two sides of the equation that the states need to look at when dealing with PBMs and the issue of pharmacy and cost. One is on the PBM side, and the other is on the provider side. So we had a multi-focused approach, and House Bill 323 basically went back into the PBM code, and it updated the Pharmacy Protection Act, strengthening, cutting out any of the loopholes as far as mandatory mail order provisions. We also included annual reporting of rebate information to payers' clients. And we also put in the provisions that we could, in that section, that prohibited PBMs from steering patients to affiliated pharmacies, prohibiting the data mining for commercial purposes, and making misrepresentations. So what we basically were doing was we were trying to make sure that we went after the steering, because what's happening is these PBMs are basically feeding the mouths of these pharmacies that they own and or affiliated with. They have financial interests in. And so that was the purpose of 323, but we did it within the PBM code. But I think the game changer was when we looked at the other side of the equation, if you will, which was 233. And I think that was the game changer, because now we were going in and we were actually going to look at the mouths that were being fed by these PBMs. And that's where we went in, and basically a lot of the same language that we had in 323, we put in 233, which is under the pharmacy section, the licensure section of Georgia's code. And basically, again, we're prohibiting pharmacies that are owned by PBMs and insurance affiliates from poaching patient information for commercial purposes. In other words, anything outside of patient care purposes. And what it does is it prohibits pharmacies from receiving self-dealing referrals from their affiliates and billing for the same. And it also had provisions in there about prohibiting pharmacies from mailing drugs when a physician indicates a direct pharmacy consultation, which can be waived. But it also mandates that it requires pharmacies to disclose affiliates to our board and gives the Board of Pharmacy oversight. And we think that this was a game changer. And again, in the sense, we weren't going after an insurance company or PBM, but we were going after actual providers who were affiliated with or owned by an insurance company or PBM. So we wanted to also make sure that we were focused on patient choice, and I think that's what we're seeing all across Georgia, is an access issue, especially in our rural areas. Not only in our rural areas, but a lot in our rural areas. And we wanted to make sure that we were focusing on patient choice. Again, the game changer was the oversight, putting the oversight of this law to the pharmacy board. So that's where we think that as the states go forward, as Georgia goes forward, but I also urge other states to think outside of the box, because if we look back over the last 5 years across the state, especially with everything that's going on within the PBM prescription drug arena, the issues of spread pricing, certainly what's coming out of Ohio and other states that are on here, we're starting to see these issues, being talked about more and more, and we're starting to see legislation. But I would urge you to be cautious in what you do, in as far as the state's ability to attack this problem through the insurance code, if you will, and maybe look at alternative ways to do this and use the state's power, purview, if you will, to use regulation and licensure, which traditionally falls squarely in the historical primacy of the state. So that's the issue that we saw in Georgia, and I think would be helpful going forward to for other states to start looking in different ways to address the problem or thinking outside the box. I'd be happy to take any questions.
Great. Thank you, Representative, for providing that perspective. And we're going to now open it up for the question and answer period. So please continue to enter your questions in the Q&A box on the bottom left-hand side of the screen, and I'll ask our speakers to address them. And then, so our first question, and I'll pose this to our state respondents, and then Ms. Brooks-LaSure, if you would like to chime in after. So we understand there's many important voices to bring to the table when discussing these issues. And so how are you bringing, or how did you bring key stakeholders together to discuss them, and what was that process like? And maybe start with Assemblyman Wood.
Yes, thank you. Appreciate that. That's a great question. Our bill, AB 72, related to surprise billing, actually came about because of the defeat of a bill the year before. I made it clear when that bill was being debated that I would bring stakeholders together to actually do that, and we indeed did. We invited to put all around the table insurance companies, providers, and state government around the table with legislators on both sides of the aisle. Our bill had bipartisan support throughout the process. And not only did we invite them, they came, and we kept them at the table throughout the process. And I think in cases where the issue, it's not a partisan issue in any way, I think that alone was helpful in keeping folks at the table. But we invited them, and they came, and we all worked together to come to a solution.
And Representative Knight, do you have something to share?
Well, I would agree with Assemblyman Wood that the issues that we face with healthcare are not partisan, and they should not be. In regards to the PBM issue, though, in the past we've tried working with the PBMs, but basically to no avail. As we all know, there's no transparency. There's no access to anything that they do. So what I've done is trying to put together the stakeholders, from starting primarily with the beneficiaries, the patients, and then the providers, and look at it from a perspective of what's the best outcome for the health care, for the health of the patient, and so a little bit different, I think, dealing with the PBMs, because they in my working in what I've done with them, they're not going to be upfront with anyone in looking at changes.
I would agree. We had a bill in California, a bill that I did related to PBMs, and I would completely agree with Representative Knight. They didn't want to come to the table. They wanted to kill all the efforts that we were trying to do on behalf of consumers, and that made it really difficult when you have a stakeholder who doesn't want to be a part of the process.
And then, Ms. Brooks-LaSure, do you have any advice for legislators on how they could bring key stakeholders together to discuss these issues at all?
I think the two examples you've heard are really reflective of how so many of these policies are successful in getting across the finish line. As we know, healthcare issues are complex, and so you do want a variety of stakeholders that are going to be affected to have a voice in how the policy is shaped, so that you as a policymaker are seeing the various sides and able to incorporate those views. I think there are times when you have a stakeholder who doesn't come to the table, and so it's important to make sure as a policymaker that you get that you at least understand that perspective and bring together the willing participants to get to the best solution. And we all hope that in solving these issues that most people share the common goal, even if they differ on the best way to get there.
Great, thanks for your thoughtful remarks, Ms. Brooks-LaSure. And then we have a question here for Assemblyman Wood, and the question is, why did California opt for a rate-setting model instead of arbitration for your surprise billing law?
We chose that because, quite frankly, we were not sure that the arbitration would work. And I think what you're seeing play out in New York is pretty good evidence that we were on the right track. Now, it may be that the rate-setting methodology may not be perfect, and certainly there's openness to exploring that. However, when you see that in New York that the rising costs to the system have been an effect of the sort of baseball style of arbitration they have, I think we took the right track, and we're open. My door is always open. I don't pretend that everything we do is perfect, but my goal is always to protect consumers and decrease costs to the system. So we chose it because we thought it would be the most effective, and so far I think we've been right on that.
Great, thank you, Assemblyman. And then I'm going to direct this next question towards Ms. Brooks-LaSure. Are there any current or existing cross-state coalitions for purchasing power of pharmaceuticals?
Off the top of my head, I can't think of one, although I do know that that there are states that have entered into those. And if someone sends their contact information to Colleen, I'm happy to get back to them.
And I can kind of fill in here, too. We do have an extensive website at NCSL on bulk purchasing. So I recommend everybody go to the NCSL website under the health portfolio, and you'll find some information there as well. And then I have another question, and it's open to the panel. With regard to the setting of rates, have any states been approached by a group called Fair Health? And do you have any experiences to share?
I can jump in. I'm sorry, go ahead.
I was just going to quickly say that I'm actually on the board of Fair Health, although I'm not involved in any of the reaching out. But please go ahead, Assemblyman.
When we were working on AB 72, California Medical Association in particular referenced Fair Health many times, and we did look at it, but we ultimately decided to go in a different direction.
And Representative Knight, do you have any insight to share on that by chance?
No, I don't. I don't believe, I haven't been personally working on the surprise billing issue, and I don't recall being approached by Fair Health.
Great, thanks, everyone. And this is the last call for questions. If you have any, please put them in the chat box in the lower corner. All right, well, seeing none, I will go ahead and conclude this webinar and give you your 8 minutes back in your day. So thank you again, all of you for joining us, and special thanks again to our speakers and to Arnold Ventures. It's been a pleasure, and please don't hesitate to reach out to NCSL staff with additional questions if they come up after the webinar. So thank you, and have a great day, everyone.
Thank you.
Thank you.